Now, one key thing to know, hey man, let's sit you down, okay? And enough screen time. Hey there, Doc. Thanks again for tuning in. Let's get started. So today's video, we're going to be focusing on the techniques of anesthesia. I'm going to give a bit of a summary as to the different types that we use as dentists, and then we're going to move into the maxillary region of the mouth, which is the upper jaw, basically. So nice and easy today. So to begin with, there are two main types of techniques that we use within the practice for anesthetizing a tooth or more. So we begin with the easiest of them, which is known as infiltration, which essentially means that we are numbing one tooth at a time, and we'll do it bit by bit. The key thing to know about this is that there are three parts to a tooth that need to be numbed if you want to get an all-round numbness for the patient with that particular tooth. You have the buccal or cheek mucoperiosteum, so the stuff that surrounds the tooth itself, that's the gum and the soft tissue. You have the palatal mucoperiosteum, which is the other side of things. So if buccal meant cheek, palatal would mean the palate. So that's the hard palate, which is in reference to the upper teeth. Those are the two that I've mentioned there so far, is the buccal and then the palatal. And then the really important one is actually the pulp and investing structures. So basically within the tooth, we have the pulp, which is the living part of the tooth itself, which is where the nervous and blood supply are actually kept within the tooth. This needs to be numbed as well to make sure that the patient doesn't feel anything. So those are the three regions. We have mucoperiosteum on either side of the tooth. There's two things there, and then the pulp and investing structures within as well. For infiltration, we're going to be targeting the buccal side of the maxillary for today, and then the palatal side. And within that, due to the way the bone within the maxilla is actually quite porous, it means that when we inject through, we typically get through to the pulp as well. So we're hitting the regions around the root, which means that the pulp is actually also anesthetized at the same time. Now, when we're looking at the way that a tooth works, and I'll try to bring this up on my screen now. So when we're looking at the buccal side, which is again the cheeks, or the labial side, which is in reference to the lips and the mouth, there is a target region that we really want to go for. And it lies within two axes, so the intersection of two axes. So if we were to sketch the upper central, for example, like this, and then it's got a root that comes up like that. If we were to look at that region where what we call the vertical, the long axis of the tooth is, that we can call that the y-axis, okay? We also then need an x-axis, which is here, across, and that would be known as the mucobuccal fold. Okay, so we want to target the height of the root. Easy way to remember it. This is not technical terms in the slightest, just an easy way to remember it. So the height of the tooth, height of the root here, and then the mucobuccal fold, which should cross it. Just accidentally erased it. There we go. Which is crossing it here, and we want to hit this target zone, and I'll just draw that in red. So this is the target zone that we're aiming for. So if we are around about that area for the tooth and we infiltrate it, then we're going to be getting a nice numbness for the patient there. Now, typically for infiltrations on the mucobuccal side of things, or the buccal side of things, labial, the outer facing side of the teeth, we want to be hitting around 1.5 milliliters there of the solution. Now, what will help us later on is knowing how much we've got left. Now, in a typical 1.8 milliliter cartridge, we're going to end up with 0.3 remaining. And that's going to be a very important number for us to remember for the palatal side of things, which we're going to come on to now. So with the, with the palatal side of things, we also need to have a y-axis and an x-axis. So the y-axis will again be through the center of the tooth, following that line. So the center of the tooth through the root, which means we're getting an arching form through the palate itself. And then the actual x-axis will be the midway point between the hard palate, the midway point between the hard palate and the cervical region of the tooth we're looking to anesthetize. So if I can find it on this picture here, we'll just ignore the examples for now. If we were going to work on this tooth here, for example, this one here, which is the upper left 6, I believe. This is the cervical region of the tooth. We want to be heading out towards the midline of the palate. Okay, that's the midline of the palate right there. And X marks the spot. I'll make it in red. We want to be about halfway through. Now, as you remember, we used 1.5 for that buccal infiltration, and it leaves us now for the palatal side of things with 0.3. So go ahead and inject that very, very slowly. And there's one thing, key thing actually, that I missed out. My apologies for that. The palate actually is a structure within the mouth that has very, very small amount of tissue between itself and the surrounding oral cavity. So that thin layer of palatal skin that we have is essentially the only thing between the mouth and or the oral cavity and the palate hard bone itself. So once we start injecting this region, it can be very, very painful. You'll feel a burning or a tearing sensation as the liquid goes in and pretty much pulls the skin away from the hard palate itself. So what we use is gate control theory, which is essentially a trick we play on the brain. Pressure is measured more by the body in response to any form of stimulus in comparison to a sharp gagging pain. So if, for example, I was injecting you but at the same time pressing somewhere, you would feel more the pressure than the injecting pain in itself. Of course, you'd still feel the pain of the injection, but it is a form of distraction, which, you know, it's good practice to have that in your arsenal. The gate control theory in this case is administered by using, say for example, the back of a mirror that you're using as a handpiece. You would go in and around the region. Again, we want to be applying the mirror. If I make the mirror, say, orange color, you're going to be applying the mirror, say, here. And you want to be putting a nice amount of pressure there through the palate until we see it basically turning white almost. So you're essentially cutting off the blood supply there and putting a nice amount of pressure through. Then you're going to be injecting at the same time to ensure that the pain is reduced as much as possible. And then we're looking at about 0.2 to 0.3 milliliters for that tooth. Okay, so one super important thing is with the innervation of the uppers, we have what is the lesser palatine nerve, which will affect more so this soft palate region behind here. So I'll just mark it out once more, so this whole area here. Now, if we were to infiltrate this number 8, for example, here I've circled in green, unfortunately, this can actually interact with that nerve, the lesser palatine nerve. And that can actually cause patients to gag or feel nauseous because basically you lose that sensation in that nerve. All of a sudden, that's weighing down in your throat and can just be not very fun for the patient to have. So we stop at the 7. The 7 is the furthest we infiltrate at. Okay, and that should typically do the trick on the 8 as well. So we don't really need to push as far back as the 8 if we want to get to the 8 anyway. So that's just something to know when it comes to infiltration of the uppers. And I hope that covers everything when it comes to infiltration. Okay, so everything might be slightly weird at this point with the lighting different and the sound different. But I finished everything, started editing, and then realized, wait a minute, I missed a very important thing. So I spoke about infiltrations. I didn't speak a word about nerve blocks, which is something that's super important as well. Now, fortunately for us in our university, we just need to know the theory around nerve blocks. The only thing we really need to know about are the PSA, so the posterior superior alveolar nerve block, which sits in the second molar region, and you use a short needle for that. You just make sure that you are going upwards, inwards, and backwards in the mucobuccal fold. That is the landmark that we need to keep an eye on. And those are the directions, upwards, inwards, and backwards. And then we want to also ensure that we are using that short needle because we don't want to go further than sort of 16 millimeters, because beyond that, we can start targeting the posterior venous plexus. So this is something that is, if lacerated, if we injure it, And furthermore, if you were to then inject into it, we can cause some serious damage, and the patient would not be very happy with us whatsoever. So it's not something that we as students are going to be covering, thank God, but we just need to know that those are the protocols behind it and how to ensure that we're staying clear of causing any damage to the patient. The other one is the infraorbital nerve block, which sits under the orbital notch, and then you have a nice little foramen here, which is where the injection site is. That is working on the anterior teeth through to the premolars. We use a long needle for that, and there are two ways of doing it: from an extraoral injection point, which is from outside the face, and the other one is by retracting the lip and working your way in. And again, there are some landmarks for this, but because we're not really going to be studying this or implementing it, it's just the overall understanding of where the injection site should roughly be, which I've outlined, and that's all we really need to know for this topic. I just wanted to say thank you ever so much for tuning in today, learning more about anesthetic techniques for the maxillary teeth, and hopefully we'll be covering the mandibular techniques in the next video. So see you then. Take care. Bye bye.